Hello everyone and welcome back to GH. My name is Anita and today we will be talking about obstetric emergencies. Before we start everything, I would like to thank each and every one of you who have been taking your time to watch our videos. Currently we have hit 1K in just 2 months. How cool is that? And it's all because you guys find our videos very educative, and I can't thank you enough. If you have written your exams, you did watch my videos, if it was helpful in your examination, please put down a comment section. I would like to know how the examination went. Even if you didn't pass on your first sitting, do not worry, it is nothing abnormal. But at the same time, we all get to understand that we are nervous. We tend to find the situation you not wanting to feel alone makes you nervous and unable to pass the exams. Today, we will be talking about obstetric emergencies, and we will start with shoulder dystocia. Please stay tuned, and I hope you enjoyed this section as well. Welcome back. So there are 4 things that goes under obstetric emergency considering the midwifery Osce, and these are shoulder dystocia, breech bed, sepsis, and PPH, which is known as postpartum hemorrhage. Today we will take a section out of it with the shoulder dystocia. We will try to cover everything under obstetric emergencies, and stay tuned again and hope you enjoy this section under shoulder dystocia. Yes, under shoulder dystocia or any obstetric emergency you will be doing, there are 3 things that goes under the first point, and this is very, very important. There are 3 things that are super important in your first point that you need to recognize in every obstetric emergency you try to undertake, and missing these 3 points under the first section can automatically disqualify you or make you fail in your obstetric emergencies. So the first point is your ability to recognize that this is an emergency. The second point is your ability to recognize that you need to pull an emergency buzzer. And the third point is your ability to recognize that you will need assistance of the multidisciplinary team. Yes, so if you have a situation, for example, that is the first point. So someone will ask me, then where do I get to wear my PPEs to start this emergency? So since the first point is your ability to recognize, it has been assumed that you were already in your PPEs performing something with the woman and this emergency took place. So it's like a halfway through a process or a halfway through a procedure. So either you are given a PPE to wear, that is your gloves and your apron, already perform your hand hygiene, always following the WHO guidelines. As I always say, you need to verbalize these, then you start. With or without the examiner may help you be in front, because there's a chance you will be using a dummy to perform a shoulder dystocia. So the examiner or may find someone else to be there to assist you position the dummy in a position that if you are to request, for example, Macrobert's maneuver, they will turn it in that way for you, or you will instruct them to turn it that way for you. So they act as the multidisciplinary team when you call for help. Also, under this first point, when you are recognizing the need to have a multidisciplinary team, you need to specify who you want. So you want the obstetrician, you want the senior midwife, you want the other midwives as well. You want this is a shoulder dystocia, so there's a chance that when baby comes, baby might have an injury or baby might find it difficult to breathe, so you will need a pediatrician as well to be as a standby. Then you will also need a scribe. So a scribe can either be a midwife or a maternity support worker if you have got one on you. So you need to say you need a scribe, you need an obstetrician, you need a pediatrician, you need a senior midwife, and you need other midwives as well. Although not necessarily all these people are going to come there, but you need to verbalize that you know that these are the people you will need when you are undertaking an obstetric emergency. Just to remind you that I am always going by the NMC mock and the marking criteria to teach you this. This is not something I have formulated in my mind. So I'm strictly going by the marking criteria, because when they are going to mark you, they are going to make sure that all these points are reflecting in everything you do in your Osce. So we move on to the second point, and the second point is, once you have recognized that this is an emergency, you need to let the woman stop pushing, because a shoulder dystocia is a part where you are undergoing a normal vaginal birth. Probably the mom is in a lithotomy position or a semi-recumbent position or sitting or squatting, whichever position the woman is in. Make sure you recline the bed back to become super flat. Take any pillows away which might elevate baby, because you need the pelvic outlet to open wider. So you take off all these things to become super flat. Let mom stop pushing, as I verbalize. Mom needs to, your ability to mention that mom needs to stop pushing. Then you recline the bed and take any pillows off. If you do not say that mom needs to stop pushing, automatically you are not performing a shoulder dystocia, because once you are doing a shoulder dystocia, any pushing whatsoever needs to stop. So always verbalize that mom needs to stop pushing, or if the mom has a name, probably called Lily, you just tell her that, Lily, I'm gonna ask you to stop pushing further. You don't need to stop pushing, because a shoulder dystocia is a bony problem, not a muscle problem. So mom pushing through a bony problem can cause further damage or a fracture to the shoulders, or even trauma inside the woman's vagina. So make sure that you let the woman to stop pushing. Encourage her to stop pushing. There's no need, even if she's having contractions, she should take in deep breath, recline the bed, put her in a comfortable position, and verbalize or ask the examiner, has my help arrived? Because if your help has not arrived, how are you going to perform certain things? Because when it comes to shoulder dystocia, you will definitely going to need some assistance. If your help has not arrived, verbalize what you need to do. That, okay, for example, I'm going to put you in a semi-recumbent position, or I'm going to put you in whatever position you're going to do. You need to verbalize all those things. If your help arrives, instruct your help that, let us put this lady in a macrobes position. I hope this makes perfect sense. The examiner wouldn't know what is in your head until you bring them out in the form of words. So always make sure that whatever you are doing, you are verbalizing it as you perform it. I hope this makes perfect sense. So a shoulder dystocia, as we all know, midwives, you all know, if you're a nurse, you wouldn't need to learn a shoulder dystocia. So as a midwife, if you are performing a shoulder dystocia, you need to make sure that, sorry about the background noise, but you need to make sure that it's like a step-by-step process. If you perform one procedure and that does not work, you move on to the next. Usually you give yourself about 30 seconds to intervene in whichever procedure or whichever maneuver or technique you want to do. And the first one you will want to give a go when probably the woman has already been reclined is a macrobes position. Macrobes position is definitely hyperflexing the legs towards the chest, just to widen more the pelvic outlet. Sometimes when you perform a macrobes position, it helps to rotate baby's shoulders down into the diameter for baby to come out. So you perform a macrobes position, tell them that I am going to perform a macrobes position and I will need you to help me hyperflex the lady. If it's a dummy, you move the damaged chest, the damaged thighs towards the chest level on the bed. So as I said, sometimes when they want to know your ability to think, your ability to know something, some things can be there not just to trick you, but for you to be able to recognize that no, this is not right. And for example, you can have a dummy with a pillow under the dummy. You should know that you need to take away the pillow off it. I hope you understand that. So we have the third point: you perform a macrobes position, and that is hyperflexing the legs towards the chest level. You do not let the woman to push, because this is a maneuver you are performing. The third point you need to do is suprapubic pressure. So after you've had your macrobes position, yeah, and baby didn't come out, you need to perform a suprapubic pressure. You are gauging at the vagina, trying to deliver the baby. So definitely someone needs to support you performing a suprapubic pressure. There may be a chance that the midwife may instruct you, the examiner may instruct you to perform the suprapubic pressure, because you are the one writing the exams, and they need to know that you know how to perform a suprapubic pressure. This is a hands-on technique. A macrobes position is a hands-on technique you need to perform on the dummy. Suprapubic pressure is also a hands-on technique. How do you perform a suprapubic pressure? So in order for you to perform a suprapubic pressure, probably the woman is already in the macrobes maneuver position. Then what you do is you place your hand just below the symphysis pubis, locating the baby's shoulder. You go downward and in a lateral position. So let's say that if I am just a little above the symphysis pubis, locating the baby's shoulders, I go down and slide it in a lateral position. So sliding it in a lateral position and going down is like having a bridge, where, for example, if this is baby's shoulders is just on the bridge. So you want it to go under the bridge so it can slide in. Therefore, what you have to do is you need to press it down and slide it to a lateral position, just to give it more room for it to come out. So that is how you perform a macrobes that's how you perform a suprapubic pressure. So we have talked about the first point, that is recognizing the emergency, needing the help, and pulling the emergency buzzer. The second one is instructing the woman to stop pushing, reclining her bed into a lateral position. And the third point is performing a macrobes position. The fourth one, we move on to a suprapubic pressure. If that do not help, as I mentioned, all those steps you should not exceed at least 30 seconds, because the more the baby is stuck there, the chances that the baby is going to have difficulty breathing, because there's this tightness there. And also, this is a delayed second stage process, so the chances that you may have a placenta which has already detached in can also affect, because that same placenta is the same thing transferring oxygen to baby. So at that point, baby has no air to breathe. Baby is already tight in the woman's vagina. So this is not a delayed process. You need to verbalize, I'm not doing this not more than 30 seconds. If you do a step and it does not work, move on to the next one until that works. I hope this makes perfect sense. So let us all move on to the fifth point. So we move on to the fifth point, and that is evaluating for episiotomy. You need to verbalize this. You can't give an episiotomy to a dummy. That's going to be a permanent damage. But if it had been a real person in that situation, then you need to evaluate. Why do we say evaluate? Because not every vagina is going to need an episiotomy. Some vaginas are roomy naturally. The only problem is the pubis. So as I said, it's a bony problem, not a vaginal problem. So some people naturally are roomy, that they wouldn't even need an episiotomy. However, if the woman is super tight down there, then you need to give an episiotomy. Yes, our next point is going to be deliver the posterior arm. How do we deliver a posterior arm? This is a very interesting aspect. I'm going to show you, because I don't have a dummy, but I'm going to show you, because at the end of the day, how you do your hands to deliver a posterior arm is going to show that yes, you know how to do it. So trying to attempt a posterior arm, you need to scrunch your hands together this way. As you can all see, scrunch it together to become very little. you go through the posterior way under the vagina or the posterior side of the baby. Try to locate the posterior arm. Now when you locate the posterior arm, you don't just pull, because if you pull, the chances of you fracturing the shoulders is high, the chances of you fracturing the wrist is high, the chances of you fracturing the elbow is high. So what you need to do is you need to locate the wrist of the baby. Once you've located the wrist of the baby, this part can be flexed naturally, this part can be flexed naturally, because both are joined. But imagine you are trying to pull from this side, the chances that this hand or this wrist might get locked up somewhere and causes, probably it might have been this way and you are trying to pull it out. You know, this one cannot be turned forward as compared, so there can be a fracture here. So try to locate, you scrunch your hand together this way. Let the examiner know that you scrunch your hand together, trying to locate through the vagina. Look for the posterior arm, look for the posterior wrist, and pull through. So the moment you are trying to pull through a posterior wrist, it's definitely going to flex these ones and baby's hand is going to come out. Once baby's hand is going to come out, it's going to drop, because it's like you've taken an inch out of baby, and then you try an axial traction. So as we all know, doing a delivery is an axial traction. So you try an axial traction to deliver the baby. You don't try to move it this way, you try an axial traction. So let's move on to the next. Yes, so if your posterior arm delivery attempt to do it didn't work, then we need to try an internal maneuver. So internal maneuver, usually I always pictured it in my head that it is like an internal version of a suprapubic pressure. Not gonna say this is a suprapubic pressure, I'm saying an internal version. Why do I say an internal version of a suprapubic pressure? This is because you try, just like when you were going to deliver the posterior arm, you crunch your fingers together. This time you try to go above, locate the anterior shoulder, then you internally try to rotate it. So if you were performing a suprapubic pressure, just like I say, you go downward and you slide in a lateral position. This one, you go inward and you slide it under the symphysis pubis. So that is an internal rotation. Usually in most cases it do work. Ask in each stage from your examiner. If sometimes the examiner will be like, nope, that is not working, because they want to know that you know all these steps. So as you are trying to attempt it, even if you've been able to deliver it and you've been able to locate the arm, you're pulling it out and the examiner tells you that nope, that is not working, move on to the next. Stop whatever you're doing and move on to the next procedure. So you know that, okay, I'm performing macrobes first. You tell that nope, it's not working, you move on to suprapubic pressure. Nope, it's not working, you try to evaluate for episiotomy. She will tell you that, okay, episiotomy given, or woman is rooming, no need for episiotomy. You try posterior arm delivery, it didn't work. She tell you that nope, move on to the next. You try internal rotation and that didn't work, you move on to the next. So as I said, these are, if she's to tell you that macrobes work, then she wouldn't know that you knew the other steps. So don't think that she's saying that didn't work doesn't mean that it is not going to work when you're in your actual practice. It's just to know that you know all these steps. I hope that makes perfect sense, and I hope everything is making super clear to everyone. The next point is support the woman to move on all fours. This is a very interesting aspect of trying shoulder dystocia, when trying to intervene in shoulder dystocia. Sorry, this is because sometimes some women have already had epidural and they can't even move their legs or can't even move their lower part. Trying to go on all fours might seem impossible. So ask, or sometimes they may narrate to you that mom has not had epidural, but you need to verbalize that I'm going to put you in all fours, but confirm from the examiner if mom has had a strong anesthesia that might hinder her to move in that right position. So if that has not happened, probably might have been taking gas and air or petting throughout the process, then definitely know that mom is strong enough to move on all fours. Or if mom probably is having a leg problem, The most important thing is that know that mom's legs are mobile before you can move her onto all fours. So but you need to verbalize that I'm gonna attempt all fours position. Sometimes when you attempt an all fours position, it drops down, gives the posterior aspects more room for you to deliver baby. However, it doesn't work, you move on to the next step. Yes, you probably might have done all these and still baby is not coming out. Then you need to demonstrate an awareness of additional maneuvers of the last result. Now this needs to verbalize. This needs to be verbalized, sorry, and that can be cephalic replacements. These are like more of big procedures that can cause permanent damage to baby. However, like I said, you need to demonstrate an awareness. Sometimes there's not even a need for you to do cephalic replacement. You might even end up with sevenalis, where you go back to C-section and they try a sevenalis maneuver, try to take the baby out through the vaginal way and deliver baby. However, if you need to also let them know that these are some of the things we can put in place. So if it's a bony problem, you can demonstrate symphysiotomy and cephalic replacement. Yes, after all this I've done, you need to verbalize the need that you need to debrief your lady. Let her know whatever has happened, because it can be traumatizing, be wondering, what are you guys doing to me, all this hurts or stuff. And a lot of people do come in, so they want to know what happened, although they are complying with whatever but they need to understand when everything is settled. And they also need to know that even after this has happened, they have a chance to bond with baby, debrief them and bond with baby, and perform maternal observations on the mother. Once everything is done, if there's a need for you to document anything, you do your documentation, you perform your hand hygiene. As I said, verbalize that you need to perform your hand hygiene following the WHO guidelines. Discard all your PPEs in the clinical waste bin. Like I said, clinical waste bin. Don't discard them in your general waste. So verbalize, I'm going to discard my PPEs in the clinical waste bin and perform a hand hygiene following WHO guidelines. I hope this is super good. I hope this is very clear to everyone. Like I said, these are straight marking criteria from the NMC mock I am following, nothing in addition. Just keep on practicing, that's what I'm gonna say. And I hope this was very helpful to all those who haven't had a chance to know how the NMC process with Osce is about. And you can find all the materials on the NMC site or even at the examination centers in the UK. But if you have passed your CBT, you are in Ghana, you want to have an idea of how the Osce is like, because it was very scary for me at the start, because I didn't know if I was going to get help and other stuff. I am happy to share this knowledge with you, and I'm happy to demonstrate everything with you. If this helped, if you've written your exams, I would like to know how these videos have been helping you in the comment section. Then we get, if there is anything I missed, I'm happy for you to share your knowledge with me. And I hope this has been super helpful. As I said earlier on, thank you and happy new year. I know it's been so long. I came back, but I'm coming back really strong, and I hope to finish with the midwifery Osce. Hopefully we should be able to do a bit of mental health as well. In view of that, thank you so much once again. I am highly honored to have so much people viewing my videos and like it. Some of them send me DM on WhatsApp, and it is very enlightening to know that you guys appreciate all the things I'm doing. If you want a one-to-one kind of tutorial before you go write your examination, you can send me an email, or you can just put your details or your email in the comment section. I will reply you through an email and we can take it up from there. I hope you all enjoy this, and Bye. Hope 2023 is the best of this year for each and every one of us. Bye.